Hi everybody, I'm joined here with Carla from Princess Margaret. We're at Euromigos 22 Nashville meeting. Carla, we had a discussion during the meeting around bladder-sparing approaches in the perioperative setting. And we talked about lots of different issues, but it did seem to have a role to play in the future. Do you want to just talk about the summary of that conversation?
Sure. So we talked about the fact that the demographic of patients with muscle-invasive bladder cancer who want to keep their bladder is changing. So it used to be the old, frailer patients who we would give bladder-sparing approaches and avoid surgery, but now we have a younger patient population who want to keep their bladder. So in this patient population, we talked about the fact that potentially they're candidates for neoadjuvant chemotherapy and concurrent chemoradiation. So we have to explore that further.
How are we going to select which patients we should give this treatment to? And there's some randomized trials ongoing with immune therapy in this space. What do they look like and how will they change practice?
Yeah, I think that there's a number of ways to determine which patient should get which treatment. In terms of the actual bladder sparing itself, we work closely with our radiation oncologists and our surgeons to determine locally what the disease is doing. I think systemically we can look at ctDNA and these approaches looking ahead to determine how we should be consolidating locally. And I think that our techniques are getting better, both from a radiation standpoint, systemic standpoint, and there's now about 3 or 4 or more and more trials looking at incorporating immunotherapy into the bladder-sparing paradigm.
There are neoadjuvant trials with enfortumab vedotin, there are neoadjuvant trials with CTLA-4, there are 7 neoadjuvant randomized trials. How confident are you that some of these are going to be positive?
Yeah, I think some of them will be. I'm particularly interested in the EV plus Pembro combination. We've seen some very interesting and exciting response rates up front. The question will be if that gets moved into the neoadjuvant setting, what kind of a response are we going to get locally? And in terms of endpoints, pathological downstaging and pathological complete response may be very important.
We should probably leave it there. Thank you, Carla.
Thank you.